I'd like to thank the organizers of this event for giving me a chance to present to you. I'd also like to thank the participants, both virtual ones and the one on site with me. I'd like to thank, I listened very keenly to Dr. Andrian Liu's presentation, and I think I have nothing much to put forward there. The only thing I'll urge us is to domicile what has been presented there to our settings. I'm not going to have a prescription of when you are going to start dialysis, because there is none. And maybe to put it clearly is that I'm just eliciting, we are just going to elicit, interest into digging deeper into exactly what the issues bedeviling the initiation, when to initiate the dialysis. I'll start by, I think you can move the slide for me. I have no disclosure to make. I think this question, what influences the incidences of kidney replacement therapy? Of course, it will be difficult to say what is the prevalence of kidney replacement therapy, the true representation, because you're just seated at the end of the pipe, just watching the drop which are falling. So it could be difficult to know how much water is there in the pipe. But, and therefore, the denominator might not be known. The numerator might be underestimated, because maybe one in every tens of patients are the one which you reach to have kidney replacement therapy. And when I'm saying kidney replacement therapy, I'm not only talking of hemodialysis, I'm talking of all the dialytic modalities, peritoneal, dialysis, hemodialysis, and the better option, the kidney transplantation. So, and therefore the incidence, of course, is driven by the disease behind, the force behind getting the kidney damaged to the extent that you have reached the end stage. And of course, the diabetes, hypertension. So I think we should be very much worried when we hear in our neighbor house of the diabetologist that they have fire. When you hear in the medical outpatient clinic that the clinic are heading at night, outpatients, because of the amount of patients they are seeing. That tells you now you should also put on lights, flood ones, because your house will be flooded on the other end. And therefore, the ability, another aspect is the ability of the healthcare system to identify the chronic kidney disease, and it's through the progression. Of course, you cannot treat what you do not know. So if you don't even know how much, what is the burden of chronic kidney disease, it will be very difficult to say how much you're going to treat. And of course, the level of kidney function at which the kidney replacement therapy is started. If you start at higher kidney function, it tells you therefore you have a bigger number of patients reaching there, and the availability of resources to provide the kidney replacement therapy. I think it is clear that kidney health, it needs multidisciplinary care to be delivered. And therefore, that is why the team, every person is important, from the but not least from the dietitian, the nurse educators, the pharmacist, the physical therapist, occupational therapist, basically everybody in health, because of course everybody who is living has a kidney, or its work has been overtaken by another system. So the aims of it basically is you want to preserve and remain the remaining kidney function, prevent or treat the complication, and involvement of patients, the family, the caregiver, making the choice of which modality of kidney replacement therapy they wish to adopt in the unfortunate event that their kin or themselves, they would require to have that services for themselves. And therefore, the patients you need, the patients need to be prepared. And the one who have not reached the end stage, they need to be gated so that they don't reach there. They need to be prevented from reaching the gate. In other words, here in the kidney replacement therapy platform, you are like that person who lived by the bridge where every time you used to go and try to rescue people who are dropping, who are throwing themselves into the river. But that did not solve much. When he went up there to see why are they dropping, why are they throwing themselves into the river or committing suicide by that, now that is when the number of people jumping, committing suicide, and his work also became less. Of course, I know your work should become less, but more fulfilling and more rewarding, I believe. Next, I would speak about the pre-dialysis education programs are important. I think I have taken some time to talk about what should we do or what could be done to prevent this number so that we don't agonize with the numbers we cannot treat. And I think for a health worker, it's a moral dilemma when you're faced to choose who to treat or who not. And more often than not, you might not be able to tell who will live or who will die. So that prerogative should not be a health professional, health care providers' prerogative. But unfortunately, that is what you are going to have. So the next slide, the facts, the kidney replacement therapy, there are facts, that it is costly. And this is exactly what will make it even worse, because in the policymakers, politicians, politics, those things go hand in hand. And of course, the number of the people you reach is important. So you cannot equate dialysis in a public health perspective to other measures like deworming. You see, like one dialysis can deworm a whole county. One session of dialysis can deworm a whole county, for one person, and can deworm everybody in the county. Albendazole. Now, going to convince this person, the system and the government and the policymaker that this dialysis, one person, twice a week, thrice a week, at this amount, I think you'll have to have even economists there with you, and maybe actuaries also to help and put sense that this, and justify why should you allocate more resource to this. So all patients are likely to reach end stage, basically, and therefore you should prepare for that. Once the kidney replacement therapy is started, it may continue for many years. I have not said for life, I've said for many years. Of course, this one you have said that the predictors, they are the drivers, but of course you can extrapolate and maybe try and imagine, or try and extrapolate and try and and forecast or foresee the number you are likely to get, holding all the factors constant, which is not likely to be the same, because in a living system, things are not, it's very dynamic. So this one I've put here for all of us, all these are found in the references written, but you can see a patient who you have been following with this problem, and over the time you have been monitoring his kidney function, holding everything constant, you can extrapolate and say, at this time, we will be at a given point. However, if there happens that the patient gets something which injures the kidney further, you get another lower level of EGFR, and that nears the dialysis or the kidney replacement therapy need. Therefore, I think I will say this, the commonest cause of CKD, the commonest risk, the highest risk of CKD is a history of AKI. So if somebody had had an AKI, follow that, because he is at a high risk of developing CKD. Again, the commonest risk of the highest risk of CKD is AKI. In other words, somebody who has had CKD, which is stable, what will dip him into or her into the needing the replacement therapy will be an insult which will orchestrate an acute kidney injury. You understand? And therefore you can actually say, if you have ever been bitten by a snake, when you see a rope, you run. That is what you should be telling. If you have CKD, if the patient has CKD, please follow, so that you'll be followed every other time, so that you don't suffer the consequences of malfunctioning kidney. Next. So low EGFR, rising serum phosphate, those are some of the markers. But the one in red is there is no single measure that can be used to determine the right time to start dialysis. Different places in the globe, like in Japan, they had to start the dialysis at GFR of 5, which moved to GFR of 6 in 1989. And of course, this also will translate to a higher number of patients. United Kingdom from 6 in 1997 to 8.6 in 2014. The United States, again, there's a report of the difference in that the dialysis was started at a consistently lower EGFR within the Department of Veteran Affairs, which is an fee-for-service health service than the others. In other words, also there's something called moral hazards. I think moral hazards that somebody, because the service is available, because like those are insurance terms. You want to utilize it, it can be utilized, and therefore that you'll find, like if you say this service is available for everybody, so everybody will try to get a share of the service, even if they are not rightly so needing that service. So next slide. So there are limitations of purely clinical approach to when to initiate dialysis. So when we wait for the patient to be symptomatic, you know what will happen. The chronic nature of the disease, that it changes, but the patient might not know that he has moved to another. Then the protein intake which will follow, and the patient may gradually reduce the activity as the exercise tolerance declines, and therefore you might not know whether it is the disease which is taking. This is, I think this is, there has been limitation of purely laboratory-based, result-based approach in the initiation of dialysis. And this paper you can see next, this paper, early to the graph, yeah, that one. Early initiation of dialysis, beginning initiating it when the residual function is still available, or starting it when you are near the edge, it has not shown benefit other than it had not shown benefit in survival or quality of life. In other words, only that it had a cost, a higher cost. When you started at a higher GFR, of course, you are going to get higher cost to treat. I think these are some of the statements which need to be borne in mind, that dialysis has a finite lifetime. It has a finite life. You know, there will people will reach to dialyze, and therefore you do not rush to start it when it is not needed, because when you start, this time you start ticking, and now you are reducing the lifetime. You have neared the start of the clock to start ticking for this lifetime bound, finite life bound intervention. And starting dialysis in the first step is a lifelong commitment to kidney replacement therapy. So maybe even if you start a patient on dialysis, you should be thinking of transplantation or dialyzing that patient for life. So because you are not likely to reverse. Starting dialysis at eGFR of 9 compares with that starting of the one of 7.2. It has shown no difference in quality of life, that when you said. And starting dialysis earlier, it was not associated with better quality of life, only higher healthcare cost. And therefore, incremental start of HD using like twice the rice, using twice rather than thrice a week treatment may be sufficient for the patient with the residual kidney function. Not one shoe fits all. It does not mean everybody needs 3 or everybody needs 2. You could look at what benefit you accrue by these patients getting to dialysis. Next slide. I think those are the most patients with CKD are suitable for treatment with both PD and HD. So you should have neutral, modality neutral counseling for the patients. Unfortunately, our patients just crash rad in our place and you are resuscitating, you're fighting for life. And at that time, you don't even have time, even if you have followed them for a longer time. And this is a graph showing the survival advantage of hemodialysis relative to peritoneal dialysis. And there's some evidence that PD may be inferior to HD over a long time, not at the initiation. And you don't know whether the patients will reach that time. When choosing the predictors for choice, those one, of course, a social worker is very necessary. A psychologist is also necessary to assist the patients and the caregiver and their kin to choose the modality or what they wish to. However, this might be very theoretical in our setting where we don't even know when the patients will come, whether he will come in which shape. Next. So the economic factors must be borne. Next slide. Next. Economic factors must be borne in mind when we are initiating the dialysis, and the physical preferences of the patients must be borne in mind. Next slide. And the decision whether to offer renal replacement therapy should be based on the availability of the facility, selection of patients by the healthcare team, rationing versus rational dialysis treatment, and predictive factors. If you think that the activity, the intervention will be futile, I think should be clear. So you advise a patient about the prognosis, conservative kidney care. The patients who does not want to be dialyzed, you should also get the care, the advice, and management of disruptive patients. the one who might be very destructive. You understand what I mean? And the resuscitation and withdrawal of dialysis. These are issues which should be borne in mind. But the ultimate responsibility, the key principle underlying the process of withdrawal of dialysis, the ultimate responsibility for the decision rests with the physician, not the relative, because you are at a higher level to know whether these activities, this intervention is futile. And the patient's interest and dignity should be protected at all times. And the process should not be rushed. If there is any doubt about the correctness of the decision, treatment should be continued. There should be an open discussion, and the psychological needs of the healthcare team should not be overlooked, and palliative care must be given the most appropriate environment to operate. When you are lost, I think this is what I will say at sea, just basic principles of medical ethics, the autonomy, the people have the rights to control what happens to their bodies. Beneficence, all healthcare providers must strive to improve the patient's health, to do the most good for the patients in every situation. Non-malfeasance, first do no harm. And justice, this which demands that you should try and be as fair as possible when treatment to the patients and allocating resources medically is concerned. You should be able to justify your action in every situation. It might be difficult, but that is what I will say. Thank you very much.